Alright, let's talk about some of the high yield facts for USMLE Step 1. Okay, what do you think, what kind of virus can cause laryngeal papilloma, usually benign laryngeal papilloma of the true vocal cords? HPV 6 and 11. Now, these laryngeal papillomas are benign papillary squamous proliferation usually found on the true vocal cord. Remember, those true vocal cords have stratified squamous epithelium, and HPV actually has predilection towards stratified squamous epithelium. How can it be transmitted? It can be transmitted from mother to fetus. That's a vertical transmission prior to delivery. And usually in the vocal cords, you will see finger-shaped, warty, grape-like lesions. The next one is, what kind of cells classically do you see in any kind of HPV infection? The answer is coelocytes. They usually have characteristic perinuclear halo, which are classical hallmark for HPV infection. Now let's say you diagnose someone with hypothyroidism. What supplement would you give them? Would you give them T4 or T3? It's usually recombinant form of T4. So whatever levothyroxine supplement you are giving to the patient is actually recombinant form of T4. That's levothyroxine. Now, since you know HPV 6 and 11 can cause benign laryngeal papillomatosis, what do you think can cause condyloma acuminata? It is still HPV 6 and 11. You should not confuse this condyloma acuminata with condyloma lata, which you usually see in syphilis. What are some of the HPV subtypes which are high risk? Those are HPV 16, 18, 31, and 33. And if the question is what is the most common cause of vaginal cancer, it's the high risk HPV subtypes 16, 18, 31, and 33. And in fact, actually 16 and 18 accounts for more than 70% of the cases of vaginal carcinoma. Now, why do you think HPV 16, 18, 31, and 33 are high risk HPV? They actually knock out P53 and RB tumor suppressor gene. Like, for example, HPV, high-risk HPV 16, 18, 31, 33 would encode proteins like E6 and E7. E6 specifically knocks out what? P53. And E7 specifically knocks out RB, that's retinoblastoma. Now, both are tumor suppressor gene. Now, when you knock out or when you have loss of function of tumor suppressor gene, there is nothing which is suppressing cells from proliferation. So your cervical cells will keep on proliferating, and you might end up getting cervical intraepithelial neoplasia, right? CIN, which is a dysplastic precancerous lesion of the cervix, and that's usually happening because of loss of tumor suppressors like P53 and retinoblastoma. Again, E6 knocks out P53 and E7 knocks out RB or retinoblastoma gene. If you were to choose, or what's the most common type of cervical carcinoma, what would you choose? Squamous cell carcinoma or adenocarcinoma? It's usually squamous cell carcinoma. Adenocarcinoma is around 15% of the cases. Squamous cell carcinoma is around 80% of the cases, and both are actually related to HPV. Another important thing is, what's the gold standard procedure for screening for cervical cancer? So the answer is pap smear. When should you start pap smear screening? It's 21 years. So from 21 to 29 years, you should do pap smears every 3 years, right? And from 30 years onwards, you can do pap smear every 3 years, or if you want to do it less frequently, you'll have to do pap smear with HPV DNA. Then you can increase the frequency to every 5 years, right? So if you do solely pap smear after 30 years, you have to do it every 3 years. If you do pap smear with HPV DNA, you can do that every 5 years. Now you know that there are some of the benign HPV virus and there are some of the high-risk HPV virus. And the thing is, now, since we know the virus, why don't we vaccinate? And so now we have Gardasil 9, which can actually protect and vaccinate against 6, 11, 16, 18, 31, and 33. So that's a 9-valent vaccine that will cover all the subtypes, including, 45, 52, and 58 as well. What do you think HPV 1 to 4 can cause? They can actually cause verruca vulgaris. They are cutaneous warts. So HPV 1 to 4, verruca vulgaris, HPV 6 to 11, condyloma acuminata, which is anogenital warts, and then high risk HPV can actually cause cervical cancer. What is the most common risk factor for squamous cell carcinoma of the penis? It's still high risk HPV 16, 18, 31, and 33. 66% of the cases are from high risk HPV. What kind of chromosomal anomaly is associated with rocker bottom feet and microphthalmia? It's Patau syndrome, trisomy 13. You can also see cleft lip and cleft palate in the patients of trisomy 13. Name a selective culture medium or agar which can be used to isolate Neisseria gonorrhea or Neisseria meningitidis. That's Thayer-Martin media, right? That's also called as VPN media, which actually contains vancomycin, polymyxin E, also known as colistin, nystatin, as well as trimethoprim. Now, if you don't use these antibiotics, you can have other bacteria which can be growing in the agar, but if you use Thayer-Martin media, it selectively grows Neisseria meningitidis or Neisseria gonorrhoeae. How can you differentiate Staph epidermidis and Staph saprophyticus based on novobiocin sensitivity? So Staph epidermidis is novobiocin sensitive, whereas Staph saprophyticus is novobiocin resistant. Now, Staph saprophyticus is classically associated with UTI in sexually active females. Let me ask you this: what's the most common cause of UTI in sexually active females? The answer should be E. coli, right? If they specifically mention characteristic of Staph saprophyticus, then you can mention that, okay, it is Staph saprophyticus. But if unless otherwise stated, if they just ask UTI common cause in sexually active females, your answer should be E. coli. What are some of the group D streptococci? Now, they can be two types. They can be enterococcal as well as non-enterococcal. Enterococcal group D streptococci includes Enterococcus faecium and Enterococcus fecalis, whereas non-enterococcal group D streptococci includes Streptococcus galacticus, which was formerly called as Streptococcus bovis. Now, usually these Enterococcus species are very notorious in antibiotic resistance, especially vancomycin resistance. So you might have to use higher antibiotics like linezolid or tigecycline. Which is the toxin produced by Clostridium tetani? That's titanospasmin. And what's the mechanism of that toxin? It actually travels retrograde through motor neuron, and ultimately it inhibits the inhibitory neurons, like also called as Renshaw cells, right? So it will prevent the release of GABA and glycine, which are inhibitory neurotransmitters, especially in the spinal cord. So it cuts or cleaves the snare protein, and it will inhibit the release of inhibitory neurotransmitter like GABA and glycine, eventually causing spastic paralysis, trismus, and rhizus sardonicus. What is Pott's disease? That's actually extrapulmonary tuberculosis, especially the one that involves vertebral body. So if the TB spreads to vertebral bodies, which is also called as tuberculous spondylitis, that's Pott's disease. What is one of the virulence factor for Neisseria species which can actually facilitate their survival along the mucosal surfaces? That's IgA proteases, right? That will cleave IgA at its hinge point. So IgA is a mucosal immunoglobulin, right? Because of that virulence factor, this Neisseria can stay in the mucous membrane. One thing to keep in mind is Neisseria gonorrhoeae is actually facultative intracellular organism. That means the classic description you'll see is you are finding gram-negative intracellular diplococci. That's classical of Neisseria gonorrhoeae. And what do you think? Is Neisseria gonorrhoeae capsulated or not capsulated? It doesn't have capsule, right? This is actually in contrast to Neisseria meningitidis, which is actually having polysaccharide capsule, which inhibits phagocytosis, and that's one of the virulence factor of Neisseria meningitidis. And in fact, we have vaccine against that polysaccharide capsule. Do you think we have vaccines against Neisseria gonorrhoeae? No, it's because of their important virulence factor, which is the pili, which allows attachment to the surfaces, and they actually have antigenic variation. Because of that antigenic variation of the pilus protein, we actually have no vaccines. So Neisseria gonorrhoeae has no vaccines. And this pili are also called as fimbriae. So Neisseria gonorrhoeae, we don't have any vaccines, but for Neisseria meningitidis, we have polysaccharide vaccines. Before 2014, we had no vaccine against Neisseria meningitidis type B strain, but now we have vaccine against type B strain as well. So now we have quadrivalent capsular polysaccharide vaccine for Neisseria meningitidis. So all the college students living in the dorms should be vaccinated for this Neisseria meningitidis bacteria, because it can be easily transmitted via what? Respiratory as well as oral secretions. What is that syndrome called as, which is one of the rare complication of pelvic inflammatory disease caused by Neisseria gonorrhoeae, which can actually involve the liver, and there'll be inflammation of the liver capsule forming violin string adhesions. What is that called as? That's Fitz-Hugh-Curtis syndrome, right? So you have to remember two most common causes of pelvic inflammatory disease, rather infectious causes: Chlamydia trachomatis and Neisseria gonorrhoeae. What's your diagnosis if an infant less than 24 hours is coming with bilateral non-purulent discharge and the conjunctiva is hyperemic? That's a chemical conjunctivitis. What's the management? You use artificial tears. What do you think is your diagnosis if the infant is of around 2 to 5 days and is now presenting with bilateral purulent discharge, and there is marked conjunctival injection and eyelid edema? What is that? That's neonatal conjunctivitis due to Neisseria gonorrhoeae infection, right? That's gonococcal conjunctivitis. Classically happens in 2 to 5 days of age. How would you treat? You have to give IM or IV cefotaxime. That's a single dose. You can use topical erythromycin as a prophylaxis. Now, topical erythromycin as a prophylaxis can itself cause chemical conjunctivitis. So just to keep it in mind. And what do you think is your diagnosis if an infant who is coming at around 5 to 14 days with unilateral, let's say, mucoid, or let's say bilateral purulent discharge, and there is only mild eyelid swelling? So it's not a dramatic presentation but more of an insidious presentation. 5 to 14 days. What's your diagnosis? Then it's chlamydia conjunctivitis, right? And the treatment is going to be oral erythromycin. And then at any time period, let's say up to 14 days, from birth up to 14 days, if you see non-purulent discharge on both the eyes, and there may be some corneal involvement, there can be some systemic manifestation like fever, you should also keep viral conjunctivitis like herpes simplex conjunctivitis in mind, especially if there is corneal involvement. Now there, the treatment would be IV acyclovir. So the bottom line to remember is, first 2 to 5 days of infection, you have to think about Neisseria. 5 to 14 days of infection, you have to think about chlamydia. And if it's within first 24 hours, you think about chemical conjunctivitis as well. And if it's coming during any time or any period where you see non-purulent discharge with corneal involvement and with some systemic manifestation, you have to also keep viral conjunctivitis like herpes simplex virus conjunctivitis in mind. What do you think is your diagnosis if a patient is coming with unilateral swollen knee, which is red, hot, tender, sexually active, does not use any contraception or does not use actually any barrier protection? So asymmetric joint involvement, red, hot, tender joint, that's septic arthritis of the knee, right? That's usually musculoskeletal complication of Neisseria gonorrhoeae infection. If you do a joint tap, that will be showing you purulent synovial fluid, but that will not show anything in the Gram stain, because remember, Neisseria gonorrhoeae we talked about is facultative intracellular organism, so you won't see anything in the Gram stain because it's intracellular organism. What serotypes of chlamydia trachomatis are associated with neonatal conjunctivitis? D through K, right? It's just easy. You just fill in few letters from D to K and it's easy to remember that can cause STIs. What is the first line prophylaxis and treatment for pneumocystis jirovecii pneumonia? It's Bactrim, right? TMP-SMX. What if you are allergic to TMP-SMX or sulfa drugs? You can use Dapsone or Atovaquone. They are alternative options for treatment or prophylaxis. What bug can cause Chagas disease? It's caused by a flagellated protozoa. Remember Trypanosoma cruzi? Trypanosoma cruzi can cause Chagas disease. Who's the vector for Chagas disease? Reduviate bug, right? Also called as kissing bug. More specifically, also called as tritomine bug, right? So reduviate bug, kissing bug, or tritomine bug is the vector for Chagas disease. And what it does actually, it will give you a painless bite followed by defecation, right? And that defecation has that protozoa present. What do you think is your diagnosis if a patient is coming with fever, hepatosplenomegaly, pharyngitis, and lymphadenopathy, like young patient? That's infectious mononucleosis. It's caused by what? That's Epstein-Barr virus, right? EBV. And what's the pathophysiology? What will you see in peripheral smear? Atypical lymphocytes. Why? Because EBV binds to B21 and ultimately it will lead to proliferation of the lymphocytes, classically atypical lymphocytes. Now the lymphadenopathy classically is in posterior cervical nodes, which last about 2 to 3 weeks, but nowadays, the questions would also mention about anterior cervical lymph node involvement. Now don't confuse this kissing disease from kissing bug of Chagas disease, right? Kissing disease is infectious mononucleosis caused by EBV, and kissing bug is actually vector for Chagas disease, Trypanosoma cruzi. Now EBV is also associated with many cancers, especially let's say nasopharyngeal carcinoma, right? Especially in East Asian populations. Now, what do you think is the diagnosis if you have a male patient who is having, sex with men? So he's coming with mild pharyngitis, lymphadenopathy, and some splenomegaly. Doesn't really have some, abdominal symptom. There is also a slight morbilliform rash. If, you're thinking about EBV and you order monospot test, but the monospot test is negative. So there is lack of heterophile antibody production. So there is no agglutination of sheep or horse blood. So because there is no heterophile antibody production. You also see some lymphocytosis or atypical lymphocytes on the peripheral smear, but these all symptoms are with negative monospot. So which herpes virus can actually cause mononucleosis with a negative monospot test? That's CMV, right? That's HHV5. Now, since talking about CMV, you also have to say which herpes virus is associated with causing retinitis in immunocompromised patient. Your answer is again CMV. It's cytomegalovirus. Which herpes virus is associated with characteristic owl's eye inclusion in the infected cell? It's again CMV. Don't confuse this owl's eye inclusion bodies from owl's eye binuclei, which are classically seen in Reed-Sternberg cell of Hodgkin's lymphoma, which is actually associated with EBV. CMV usually remains latent in mononuclear cells. It could be T cells, B cells, or macrophages, whereas EBV remains latent in just B cells. One important serological antigen is produced by EBV if the infection is active and productive. That's a viral capsid antigen, that's VCA. And if the EBV is causing some latent infection, you would classically see EBNA protein, Epstein-Barr nuclear antigen. So it's just a matter of what serological antigen you are expecting. So if you are expecting a serological antigen, if the infection is active, you have to think about VCA or viral capsid antigen. And what serological antigen you should be expecting in latent infection caused by EBV, that's EBNA, Epstein-Barr nuclear antigen. And it is the EBNA or Epstein-Barr nuclear antigen which is responsible for contributing to Hodgkin's lymphoma as well as Burkitt's lymphoma, because it's classically found in latent cell. Now, we talked about CMV retinitis. What are other complications which you can see in immunocompromised patient caused by CMV? It can cause CMV esophagitis. It can cause CMV colitis. The classic description of CMV retinitis is those cotton wool spot, and for CMV esophagitis, you'll see those linear ulceration in the esophagus. CMV can also cause interstitial pneumonia in patients with HIV. So you again will see owl's eye inclusion bodies if there is an infection from CMV.